and leave those, maybe the other fluorescent too. Yeah. Ooh, this is nice. Okay, good. All right. All right, better. Okay, good morning, everybody, or good afternoon, everybody. Sorry if we had a little. I'm assuming everybody at home can, or virtually can hear me as well. It's a little unusual times now, giving combination in-person and virtual talks simultaneously, but we can get through it. So good afternoon. I'm Frank, I'm a pediatric urologist here. Obstructive urology in children, and hopefully get some light on some conditions that you might encounter. So just a little bit of embryology. There is urine that can significant part a lot today, and normal goes to the
Did you hear me? Oh, I told you, I said I can hit record.
Should he get started?
Is it still? Okay, I think it's still working. Okay. My apologies, it just popped off for a second. Anyway, these conditions, with the really conditions early on. Ureter seals, posterior valve, anterior urethral valve, circumcision, and as it can continue to minimize urinary tract infection in association with these conditions. Just a schematic of urinary tract development, just to give or from your embryology or your medical school, but essentially most of the urinary tract by 10 weeks gestation. Just to give you an idea of the time when conditions sort of can be manifest. Just to break it down a little bit, the development of the ureter, it arrives from the ureteric bud, which is off of the mesonephric duct. Very important that it from the urogenital sinus, and the reason why is if it's close or too far can determine how that ureter implants into the bladder, and that will determine its tunnel length, which can predispose to either obstruction or reflux, which I'll get into in the subsequent slides. Anyway, the duct and the ureter enter the urogenital sinus, and then and the moves craniolaterally, and the moves caudal-medially, and forms the ejection here. So that's, like I said, on how ureter implanted the body, where it comes off of the mesonephric duct. So if it's too close to the urogenital sinus, what happens is it ends up migrating too far. As a result, you can get reflux, and that's thought to occur because the tunnel of the ureter, the intradetrusor tunnel, is short, and therefore when the bladder fills, you get reflux, or the ureterovesical junction is compromised essentially, and you get reflux of urine up to the urinary tract, which can predispose the kids to getting infections, urinary tract infections. If it's too far from the urogenital, if it buds off too far, you get delayed separation from the mesonephric duct, and what happens is the ureter goes along for the ride with the mesonephric duct, and you get implantation of the ureter more medially, inferior medially into the bladder, which can cause obstruction. You can have a bladder neck, ureteral orifice, so to speak, and that's not good for proper drainage. It can even end up in the vagina or the vas deferens or the seminal vesicles medially because of that its close association with the mesonephric duct. If you get two buds, for example, or early separation of that, you can get duplication of the ureter. You can have a complete duplication in the situation where you have two ureter buds, and that you have duplicated collecting systems, which also have their associated issues with them, and I'll get into those in the subsequent slides. But that's another thing that could happen, another scenario. If you have persistence of Chihuahua's membrane, what happens essentially, you develop a ureterocele, which is almost like, if you know glass blowing, where you can it's basically, that's what it is. It's covering the tip of the straw, and it can be a source of obstruction in the urinary tract, and you can see on antenatal ultrasound. And if it's obstructive, obviously we can intervene and treat that. Prenatal detection, just to get a little bit into this, we can see a lot of things prenatally, tract hydronephrosis, obviously, which can be associated with either obstruction or you don't necessarily see hydronephrosis in a kid with reflux. You might see a completely normal antenatal ultrasound. You might see a normal postnatal ultrasound. Obstruction, typically you will see some degree of hydronephrosis, swelling on that kidney. And cheliectasis is just dilation of the calyces. Not all associated with both pelvic and calyceal dilation. Pelvis get prenatal, which is nicely helpful. Obstructed the kid is, or the fetus is. Parenchyma, you can get a sense of how healthy this kid is. Antenatal ultrasound, if you can see how echogenic the kidneys are, or in the parenchyma, or basically give you a clue if the kidneys are going to be unhealthy in this, if significant obstruction, if cystic structures within the bladder, such as a ureterocele, you can see urinoma, which is urine outside, or fluid collection outside of the kidney. That's sometimes associated with an obstruction. And
Hey, Dr.
then
Penna.
the keyhole sign in oligohydramnios, or low amniotic fluid, and the keyhole sign is kind of associated with posterior urethral valves, and I'll be talking about that condition at length towards the end of the talk. Just to give you an idea, ultrasound is incredibly helpful, and prenatal ultrasound has come a long way in giving us some clues as to what's going on with the baby. And then this is an interesting slide. It kind of talks about what pathological conditions, the likelihood of having that pathological condition based on the severity of the hydronephrosis. So just to give you an idea, ureteropelvic junction obstruction, where the ureter meets the pelvis, a UPJ obstruction. If you have, the more severe the hydronephrosis, the more likely you have a UPJ obstruction present. So you can look here, mild hydro, 4.9%. If you go up to severe hydro, you have about a 54% chance of having a UPJ obstruction. So that's correlative. Reflux, on the other hand, gets back to what I said earlier. You can have severe hydro on you can have severe hydro on ultrasound, but it does not, the hydro increases, it does not increase the risk of reflux, because you can have a completely normal ultrasound and still have reflux. So that's not as helpful in diagnosing reflux, and that's why postnatally we typically get a VCUG, which is a voiding cystourethrogram, and that helps us diagnose that sort of backflow of urine up to the kidney, which is reflux. Valves, obviously also an obstructive process, increases, the risk of that increases with the degree of hydronephrosis that we see.
Can I stop you for just 1 second?
Yes.
The Zoom world is really, it's like cutting in and out.
It
some
is,
reason.
okay.
Yeah.
If you guys can hear me via Zoom, I apologize. I can
I don't know
try
if it's
doing.
the connect-
Issue.
And then for some reason, your presentation went away on the Zoom call. You might have to hit share screen one more time.
Okay, let me see. Share screen. Well, whatever, when I think you started recording, it might have popped me off. I
Oh,
noticed some
really?
change. Yeah, I noticed
Okay,
some
I think
change.
Ash hit record for me upstairs.
I think we're back.
Okay.
Okay, everybody who's listening, I apologize. I changed the network from guest. I see a thumbs up. That's good.
Okay, perfect.
From
All right.
guest to the regular network, it might be a little more solid of a connection. Sorry, I don't think you missed too much. Let me just kind of go quickly review. I talked a little bit about embryology and the development of the ureter via the ureteric bud, and how it can duplicate or lead to reflux or obstruction based on where in the process it comes along, where it comes off that ureteric bud. I was just talking about how helpful prenatal ultrasound is in giving us some clues about what kind of condition that the fetus has, and we can know that pretty early on. Anyways, moving on here, this is just some conditions here just to kind of go over with you. Obviously, we talked about the point of this slide is just to say you can have obstruction anywhere in the urinary tract. Obviously, ultrasound can give us some clues as to where this obstruction might be. Obviously, if you have a UPJ obstruction, you're going to see a markedly dilated pelvis, but not necessarily at all a ureteral dilatation, because everything above the obstruction is dilated. Everything below the obstruction should not be dilated in theory. So that's kind of a clue that can kind of help you out. This is the SFU grading for hydronephrosis. It goes grade 0 through 4, and that's just I'm a very visual person, and obviously looking at the lower portion of this slide will give you an idea of what it kind of looks like on ultrasound. And there's different grading systems. This SFU grading system is very helpful. There are other ones where you can describe it as mild, moderate to severe, or severe hydronephrosis. But this is the one that we commonly use, and you can see that there with regards to how the calyces look and whether or not there's thinning of the parenchyma on SFU grade 4, for example. Obviously, in that situation, those usually are severely obstructed kidneys that really taken a hit with regard to function. So let's talk about UPJ obstruction. This is very common. I'm sure you probably have seen a patient with severe hydronephrosis with significant pelvic and calyceal dilatation. It is the most common obstructive lesion. You can have an intrinsic UPJ obstruction where it's kind of like intrinsic scar tissue. It's essentially just how the connection between the pelvis and the ureter developed. There's just happens to be just a little bit too narrow, and it is a spectrum. So you can see kids with a partial obstruction that has some decent drainage versus a severe obstruction where you have marked dilation and renal parenchymal compromise due to that severe obstruction. It could be extrinsic as well, which is sometimes a bit more elusive of a diagnosis because it's due to a crossing blood vessel. So instead of just an intrinsic problem inside the plumbing system, you can have an anomalous lower pole renal vessel that happens to be compressing that. A lot of times those kids are diagnosed later in life because as they grow, the plumbing system becomes more compromised by that crossing blood vessel. It's not always picked up when they're younger. But it's important to kind of differentiate the two. The treatment is the same as I'll get into later. I mentioned this earlier just a minute ago, usually without a dilated ureter. So that's a clue there. 10% are bilateral too. I have done a couple of bilateral pyeloplasties, which is the surgery name for what we do to repair it. But that's less common. Most of the time it's a unilateral process. If it is bilateral, again, it is a partial obstruction. So you're having drainage of those kidneys. Otherwise the kid would not make any urine at all, right? However, we do concern ourselves with the fact that any sort of degree of obstruction in there can, over time, compromise renal function. Not in the order of months necessarily, but on the order of years. So you might have an older kid that comes into the ER with, flank pain, and on ultrasound or a CAT scan, you'll see a very thin parenchyma. due to sort of a long-standing obstruction that was not properly not diagnosed earlier in life. This is hydronephrosis, severe hydronephrosis of this kidney, just showing an ultrasound. How do we get more information beyond ultrasound? I don't order CAT scans a lot on children, mainly due to the radiation exposure. But an ultrasound is a nice tool, imaging modality to start with. No radiation, it's cheap, it's easy to do, and we can get a lot of information, as I mentioned, from an ultrasound. This shows a diuretic renogram. It's just a snapshot of how a renogram looks, which is a nuclear medicine scan. And it gives me really two pieces of information. One is function. Okay, so the MAG3, the diuretic or the nuclear medicine agent, MAG3, gets uptaken by the kidneys, and we compare how quickly each kidney uptakes that contrast. And if it's equal and it's quick uptake, it's 50-50 function. And that gives me some clues as to whether or not that a potentially obstructed kidney has taken a hit functionally, if it's slower to uptake that. And that's the initial part of the test that when we start doing that study. And then that MAG3 gets into the collecting system, and then we measure how quickly the MAG3 gets down to the bladder, and we can actually measure a T-half or a T-half life. And if you can see the image on the right, the two curves, you can see a normal kidney would peak and then drain, like the bottom curve, the lower curve, and that's a normal kind of drainage curve. The top curve, you could see it peaks, and then it kind of it stays, kind of almost flattens out there, which suggests that that contrast, that brightness, the number of counts is not coming down, it's staying in the kidney. And so we give Lasix at a time point during the study to increase diuresis, and then we measure a T-half. If it's T-half greater than 20 minutes, it's considered a high-grade obstruction. So that's just kind of a snapshot of one imaging modality that is really helpful in giving me information about whether or not a patient is a surgical candidate or not. Does anybody know who this gentleman is? I suspect not. Anybody want to render a guess? Maybe if you were urology residents, I don't know, but probably not. I have given this talk to urology residents. They don't know either, so don't feel bad. This is
Winston Churchill.
Dietl, Joseph Dietl, and apparently he's an Austrian-Polish physician who described something called the Dietl's crisis in the mid-1800s. And you might have heard the term Dietl's crisis. And what Dietl's crisis is, it's the pain episode that the patient gets from an intermittent UPJ obstruction from a crossing blood vessel typically. And they will, during periods of diuresis, they may have that obstruction challenged, and as a result, they get severe flank pain. It might come into the ER with that flank pain. So that's just the name of the crisis. He coined the term for Dietl's crisis there. This is a dismembered pyeloplasty. This is how I treat it. And you look on the left there, you can see the large pelvis. You can see the narrow segment where which is the UPJ, the ureteropelvic junction. And there's a segment there that's quite narrow, and it's an intrinsic obstruction here. In this case, I typically do this in a minimally invasive fashion, robotically. If you've heard of robotic surgery, you can do it laparoscopically as well, straight lap, but it's a little more challenging, technically speaking. But I dismember the pelvis by cutting it. And then I'll typically remove that scarred segment, spatulate the ureter, which means make the ureter. I can just kind of show you. I'm going to get up from my Zoom callers here and just show you. I'll cut out the segment here, and then I will open up the ureter this way, long ways. That way, it's able to be big enough to fit the pelvis there. And then I'll sew it up all the way around, and I'll leave a stent. Sorry, I wanted to point on the screen there. I was just showing them how I typically do this. And then I'll sew it up and leave a stent. And the kid usually stays one night in the hospital and heads home afterwards. This is about 95% successful in treating that UPJ obstruction. Good, let's move on to ectopic ureter. I'm assuming everybody is doing okay virtually. Do I get a thumbs up again, or whoever it was gave me a thumbs up? That was great. I guess I would hear if they weren't hearing me okay. Good, I just saw another thought. Okay, good, thanks. Perfect. Anyways, let's move on. Ectopic ureter, which means a ureter that's not inserting into the bladder in the proper spot, or not inserting into the bladder at all, just like an ectopic pregnancy, so to speak, right? So here you can see in a case where you have two ureters or a duplicated collecting system, you can have basically, this is just showing you, they invert their positions as they fuse with the urogenital sinus, and that's called the Weigerd-Meyer rule, which I'll get into in the next couple of slides, and it'll be more clear here than this this schematic. But essentially, what happens is the lower ureter goes into the bladder, and the upper ureter can insert more medially, and as a result can insert into the vagina, for example, and be an upper pole ureter to the vagina, or to the bladder neck, for example. And that could be an issue if the upper pole is inserting into a ectopic like that, because it could be obstructed, and that whole portion of the upper pole, the kidney, won't be draining urine properly and might be damaged over time. So this is just a schematic showing you of the multiple sites you can have insertion of ectopic ureters. In a little girl, for example, where it inserts into the vagina, the ureter, what happens is they can present with incontinence past what is the typical toilet training age. So they might be, it's rare, okay? So it's not, if some little girl's incontinent, I wouldn't jump to this diagnosis right off the bat. I would work with them on other reasons why they're incontinent. Maybe they're holding the urine for extended periods of time. They might be constipated. I would work on that sort of bladder and bowel dysfunction, which is much more common. But this is something I always think about, you know, and you can always refer and have me take a look at these kids, because I might get an MRI, for example, on these kids, which I don't order very often, but it would help me diagnose a ureter that's going to the vagina and it is constantly draining urine into the vagina, and then that's why the little girl's incontinent, essentially. She's not able to stay dry ever. And in the male, you can have, like I said, you can have a prostatic insertion. There's a lot of different places, bladder, neck, etc., which can also be obstructive in nature. This is the Weigerd-Meyer rule. So essentially what it says is, in a case where you have a duplicated collecting system, the upper pole typically inserts inferior medially, which means why it's more inferior and more medial. So you think of a bladder neck, a ectopic ureter to the bladder neck, for example, it can be obstructed. So if it's an upper pole moiety, it's typically obstructive, or not obstructive, but it's typically obstructive in nature. A lower pole moiety inserts superior laterally into the bladder. And as a result, they're more likely to reflux. If it's a lateral insertion into the bladder, you have a narrower tunnel into the bladder, and it's more likely for that urine to go up that ureter and up to the kidney and contribute to reflux and potential infection in that kid. It doesn't necessarily have to if it's under the threshold where reflux can occur. So it's kind of a spectrum. But anyway, just so you know, this kind of is a rule. If you have a duplicated collecting system, an upper pole is possibly more likely to be obstructive, and a lower pole is more likely to be refluxing. And this is just a nice CAT scan of a girl I operated on in New Hampshire when I was up there. And you can see her, this is a coronal view of her CAT scan. The left kidney you can see, I'm gonna get up again, I apologize. All of that black area is her upper pole, which is incredibly dilated. This is her lower pole of the left kidney. And you can see her ureter, upper pole ureter is dilated. It's because and this is more of her lower part of her, inferior portion of her upper pole ureter, all here. It's because her upper pole is inserting into her vagina. And her lower pole ureter is fine. That's why the kidney looks normal in the lower aspect. So this kid, unfortunately, she was older. She was a teenager. She was having UTIs, etc. And we ended up taking out that upper pole moiety. And why? Because you could see it's very thin. It's not worth salvaging that. It did not have much function because of how long it had been obstructed. So I took that portion of the kidney out and its associated ureter all the way down to the bladder. And her infections went away. So this is another kid with this is a VCUG study. And this kid has a duplicated collecting system, okay? And this kid has reflux into the lower pole moiety only. So it's lower pole reflux. The upper pole, that ureter inserts properly into the bladder and it does not reflux. So you can see here along the top of that lower portion, it flattens out. We call this a drooping lily sign. So it's almost like a drooping flower, sort of, because you can't see the upper pole of that kidney because it's non-refluxing. So you only see the refluxing portion. If this kid had no reflux, you would only see the bladder filling with the contrast and no, reflux up into that ureter or that kidney. Just another kind of example of how we diagnose these things. This is an intravenous pyelogram, an IVP. We don't do a lot of these studies because we have a lot better studies than this, but I ended up getting this. It's a little less radiation than a CT. In a little baby girl, this was one of the first kids I operated on after my fellowship independently. And she has a completely duplicated collecting system on the left. So this is not the same as a VCUG because the contrast is coming from, it's intravenous contrast. It's not intraurinary, so to speak. So you're gonna see both moieties of the kidney. On the left, you can see those two black areas, right? And there's two ureters, in fact. So she has, she ended up having a duplicated collecting system with lower pole reflux. Obviously, this is antegrade contrast coming from the top, but she also had lower pole reflux. So what I ended up doing for her was I ended up doing something called a ureterostomy, where I sewed her lower pole ureter, which was refluxing, to her upper pole ureter. So that way, all the urine drainage went into her upper pole ureter so she didn't reflux anymore. And that's just kind of a nice way of treating reflux without messing with the bladder. Anyways, moving on, megaureter is any large ureter. It's another condition. It's kind of a descriptive term. You can have a primary megaureter or a secondary megaureter, secondary to another condition, and I'll get into that in a minute. And it could be obstructing or it could be refluxing. Refluxing megaureter is vesicoureteral reflux, essentially. So you can have a refluxing megaureter, an obstructed megaureter, or you can have a non-refluxing, non-obstructed megaureter, meaning it's just dilated, but it doesn't really, it drains fine and it doesn't reflux. Why does that happen? Well, I think the last category, it could have been obstructed at one point, the obstruction resolved, but the ureter is still dilated. And that's how I explain that, essentially. But, and that kid doesn't really need anything except just kind of periodic monitoring with ultrasound. But anyway, just to kind of break it down, we don't have to go into all the specific conditions, but essentially, the condition is megaureter. And how do we manage megaureter? It really depends on what kind of megaureter they have, right? So we can obviously observe the kid. Anytime there's an obstruction, I like to treat it if it's because we worry about damage to the kidney. If it's refluxing the megaureter, if the kid is asymptomatic and not having infections, we don't have to treat it surgically. We can watch those kids. Obviously, if it's non-refluxing, non-obstruction, an obstructive megaureter, we can watch those kids. But you can, surgically speaking, you can reimplant the ureter and redo the connection between the ureter and the bladder for both refluxing and non-refluxing. You can also manage it endoscopically with cameras. But really the reason to intervene is if the kid's having infections, stones, or worsening of that swelling. Anyway, so the predictors of resolution. So how do we know which kids resolve with this condition? Mainly, the more dilated the ureter is to begin with, the more likely they are to have something done to them. If it's greater than a centimeter, typically we'll end up having to do something because, like any condition, the more severe versions, typically we intervene on, and this is no different. But a lot of them do resolve. In fact, it just depends on how severely dilated the megaureters are to begin with, if they're obstructive. So moving on here, this is just a survey looking at megaureter by 56 members of the British Association of Pediatric Urologists. Just to kind of summarize, essentially, the reason why I bring this study up is what's the significant diameter of the ureteric diameter, excuse me, it's typically greater than 7 millimeters. And this can be prenatally diagnosed. So those are kids that we ought to follow and get a postnatal ultrasound. One thing to note is a postnatal ultrasound should be done at least 48 to 72 hours after birth. And this is probably a board question for pediatrics. It's definitely a board question for urology, but if you get an ultrasound earlier than the 48 to 72 hours, you could be underestimating the degree of hydronephrosis in that kidney. Okay, so usually you wait and you can compare your prenatal with your postnatal hydro at that time. Newborns with prenatally diagnosed hydroureteral nephrosis should get antibiotic prophylaxis. And why is that? If a little kid has urinary dilatation, okay, if it's greater than 7 millimeters, it's considered appreciable. They are more likely to get a UTI and get very sick from that UTI. And that's something for you guys to know as well. What do I mean by that? Well, that urinary tract infection could quickly become a bloodstream infection. And then from there, that can quickly become a central nervous system infection. And we're talking about meningitis. And that is obviously, you're going to have to do an LP on the kid, even if it's, it's negative, you're still having to put the kid through all of that workup. So I think it's reasonable to be cautious and have the kid on an antibiotic prophylaxis for this degree of dilatation in the urinary tract. Postnatally, I would get them on some antibiotics. We can always discontinue them later when the kid's a little bit older and we're getting a better sense of what's going on. Typically, we had an ultrasound and a VCUG, potentially plus or minus a VCUG, depending. And then I talked about the MAG3 study. So those are the three studies: renal and bladder ultrasound, VCUG, which is a voiding cystourethrogram, the catheter in the bladder test where we fill the bladder with X-ray dye contrast and take a look to see if there's reflux or not. And then the MAG3 later on, usually at about 2 months of age, to look for obstruction and also just get a sense of the function of the kidney. Anyway, the reasons why we intervene in these kids, obviously, if they're getting recurrent UTIs or if they're older and they're having pain, certainly if they're having diminished function as well, if there is an obstruction there and their kidneys are less than 40% functioning, we worry about long-term damage to that kidney. Anyway, the other condition I wanted to get into a little bit was called ureterocele. And again, if you remember the embryology portion of the talk, it's a persistent of Chihuahua's membrane. That may also be a board question, certainly is in urology. So Chihuahua's membrane doesn't go away. So what you end up having is this thin filmy tissue capping the ureter in the bladder. Why is that an issue? Well, if it's obstructive, it could be an issue and it could damage that kidney, just like any other obstruction in the urinary tract that's significant enough. And so we can see that on prenatal ultrasound as well. You can have a ureterocele on a single system or on a duplicated system. In a duplicated system, it's typically an upper pole phenomenon. So the upper pole typically is obstructive, and the lower pole refluxes, as I mentioned. So, and it could be obstructive versus not obstructive. Postnatally, you can get an abdominal, you can see it as an abdominal mass. The kid can present with UTI and you can uncover that if you were to get an ultrasound. Or you can see it prolapse too. And this is a picture of a ureterocele prolapsing out of a little girl, infant. So that is one of the, that's on the differential of a mass, a prolapsing mass like that, or a vaginal mass in a little baby. Moving on here, just to show you some images. I'm very visual. I'm a very visual person, and it's nice to have less text, so you can just look at pictures and listen to me rather than read off what I'm repeating. So this is an ultrasound on the left of the kidney. You can see that's a duplicated collecting system. So on ultrasound, I'm getting up again here. The left, on this view, the left is always upper pole. It's always superior. The right is always inferior. So this is an upper pole hydronephrosis, or upper pole dilatation of the moiety there. And the lower pole looks normal. And then in the bladder, you can see this gives you a clue as to what the cause what the cause of that hydronephrosis is. This is an obstructive ureterocoel. And that's the ureterocoel. This is a single system instead of the duplicating system I just showed you. Again, also a ureterocoel in the bladder there, you can see that. So this is a DMSA scan, which is another nuclear medicine scan that we commonly get. I don't order a ton of these, but it does help give us some functional information about the kidney. In this kid, the moiety with the ureterocoel covering the ureteral orifice only has 4% function. So it's a pretty crummy kidney. And this was a kid we saw in fellowship, and we ended up incising the ureterocoel with a camera, endoscopically or cystoscopically, as we say. And then what happens is when you incise that ureterocoel cystoscopically, there is a 25% chance it can lead to reflux. So in other words, urine all of a sudden likes to go up to the kidney after the incision. And in this kid, she started developing urinary tract infections after that surgery that we did to treat the ureterocoel. And then we ended up taking her kidney out in the long run because she kept getting infections. So hindsight's always 20/20 in surgery, some in medicine in general, I think. But just to show you an example, the kids, it's typically the kids that have some degree of urinary stasis that gets infections. It doesn't matter where the stasis is. We created a situation where the kid was having stasis in her poorly functioning renal unit, and the urine was going back up, but there wasn't a lot of antegrade production of urine from that poorly functioning kidney. So she just had basically backflow of urine up to that kidney, but it wasn't draining out, and then that just set her up for failure, essentially. So it's a plumbing system, and like any plumbing system, if it gets backed up, it's not a good thing. And so kids that, for example, hold their urine for long periods of time and don't empty their bladders, and that's volitional voiding, that they decide not to void. Those kids, if they have underlying risk factors for infection, like reflux, those are the kids that we typically see present with recurrent UTIs. And if we get them to void more frequently and do some other maneuvers, typically the infections can go away in spite of having anatomical abnormalities like reflux. This is another ureterocoel here, just showing you it's a filling defect on an X-ray here. This is an IVP again. This is from a textbook, not one of my patients, but just to show you. Anyway, how do we treat this? I mentioned incising it. We can remove the kidney. We can connect the ureter, if it's a duplicated system, to another ureter and divert the urine so it doesn't drain through the ureter with the obstruction on it. Or you can just open the bladder and remove the thing, which is kind of aggressive. And there's pros and cons to doing any of those things. But essentially, I just want you to be comfortable with recognizing a ureterocoel and being able to understand that it's something that we need to get involved with if we think it's an obstructive ureterocoel. Posterior urethral valves, this is an important condition. And I've had a run of valves since I've been here. I've had at least 4 in the past year since I joined the group here. It's about 1 in 5,000 boys, okay? And this comes from, basically, I'm just going to check in the watch here. We got about 15 more minutes. I think we're doing good with time here. So 1 in 5,000, it's basically a piece of tissue, a valve. It's called a valve in the posterior aspect of the urethra, which is obstructive in nature. And the obstruction starts in utero. So on prenatal ultrasound, you will see kids with, I'll just define it: congenital obstructive membrane in the posterior urethra, which impedes antegrade flow of urine. It's a bladder outlet obstruction issue, which means that both kidneys are feeling the pressure of this obstruction. Why is that important? Well, if it's just a unilateral obstruction, you might have unilateral hydronephrosis, but the kid is making a decent amount of amniotic fluid because the other kidney is draining properly, the bladder is draining properly. In these kids, we can see something like oligohydramnios, which is a problem. If it's severe, it's a spectrum, just like every other condition I talked about. If the valves are severe or obstructive enough, you can get significant oligohydramnios and then pulmonary hypoplasia or poor pulmonary development, which can be life-threatening in the boy. So it's more or less they die of their pulmonary complications than their urinary tract complications or complications from the valves, essentially, directly. I mentioned this a little bit. It's either an anomalous insertion of a mesonephric duct into the cloaca or an incomplete dissolution of the UG portion of the cloacal membrane. So it's just a little extra membrane that should have gone away. And essentially, it's enough to be obstructive, though, unfortunately. This is an MRI study of a fetus in utero, and you can see how big the bladder is on this kid. I mean, you don't need to even put your glasses on to see it. This kid is pretty obstructed, and you can see it actually shows a little bit of the valve tissue there. So this is a kid you might see in the NICU, and especially he'll be in the NICU because of pulmonary issues more than anything. Anyways, moving on. So this is the keyhole sign on ultrasound. It's basically a bladder ultrasound, and it looks like a keyhole, right? And that's because there's such a dilated posterior urethra because it's obstructed just past there. And that's why you see this configuration. And this is kind of almost pathognomonic for valves. So how do we really diagnose it, though? It's a VCUG. We get a VCUG because we want to try to prompt the kid to void. So VCUG stands for voiding cystourethrogram. So it's cysto is bladder, urethra is urethra, gram is an X-ray. So we want to, part of the study, we have the kid void. And when they void is when we can, that contrast gets into the urethra and we can see it. And we can see how dilated the urethra is. Even if we don't necessarily see valve tissue, we can presume that there's a valve there. So an early VCUG is very important. Bladder drainage is very important. This poor kid has been obstructed since 10 weeks gestation. So we can get a 5-French feeding tube in. You know, this you would call urology at this point, and I'd come by and see the kid and get a catheter in him. Because that's the first step. We want him to be, he's been obstructed ever since his kidneys formed. We want to get him drained until we can do some surgical intervention on him. NICU support, mainly for pulmonary reasons, obviously labs. I mentioned prophylactic antibiotics, important in this kid, high risk for infection. Valve ablation is the surgery I would do. If he's big enough, I can put a camera in his urethra and actually, I just do a cold cut with we call it a resectoscope. It's a special kind of camera. I can just cut that valve tissue with the cold knife, with the scope. And that usually does the trick. I would offer circumcision at the same time due to the fact that circumcision does also decrease the risk of UTI in the first year of life, and even more helpful in kids with urologic abnormalities like this. Cutaneous vesicostomy, if the kid's too small, this doesn't happen so often, but we would have to drain the bladder by bringing the bladder to the skin. Which is obviously an open surgical procedure, but it's because we can't get a scope in him to drain it. Upper tract diversion, we don't really do that much anymore. It's basically kids that we think that there's such architectural changes to their kidneys that the obstruction is no longer just a valve issue. It's because there's kinking of the ureter, et cetera, from the ureter being so tortuous and dilated from the obstruction. But you know, I don't jump to that right away, and I actually have not done any of those independently because it's really rare to have to do that. This is a VCUG showing you a very dilated urethra with that large arrow on the left, and you can see the valve tissue with a little arrow on the right. That urethra is markedly dilated. It should not look that wide like that. And this is valves until proven otherwise. Essentially, it's valves. Again, another image showing you a very dilated posterior urethra just below the bladder there, and that valve tissue that's there. So moving on, posterior urethral valves, 1 in 5,000. Anterior urethral valves, even rarer, but I just mentioned it because just to kind of compare and contrast with valves, it's anterior. So it's a valve that's further along the urethra closer to the outside world, right? Anterior versus posterior towards the back. And you will see dilation of the whole urethra in this case, and you can see that here. This was a kid actually that I saw in my clinic in Toronto when I was a fellow. And I ended up, he was older and he had incontinence and a poor urinary stream. And it was a little bit of an unusual sort of picture and history of UTI. And I ended up just getting a VCG on him in the off chance that he was a delayed posterior urethral valve diagnosis. So that's rare, but we see that now and again, delayed valves. So kids that prenatally, they never got picked up, and we never worked them up early. But that's something to keep in mind always. Again, rare. It's like rare, like the little girl with incontinence and it's an ectopic ureter to the vagina, kind of rare. But it happens. It's something to always think about on your differential. This was the kid, again, anterior urethral valve is very dilated, and you can see the valve tissue endoscopically there that I scraped and unobstructed the kid. So we're getting close to the end here. I have a couple of quiz questions, so to speak, on valves. I think valves is probably the most high yield topic for you, just because I feel like you guys are very involved with it, because the kids often are quite ill and in NICU and things like that. So the major cause of mortality today in boys with valves is, anybody want to take a guess? Just shout it out if you know the answer. I kind of mentioned it. D. Correct. So pulmonary insufficiency in the newborn period. And it happens from time to time, but most of the kids we can get better, get them fixed up. Unfortunately, even though I fix the valve, and I unobstruct them, those kidneys have been damaged, okay, because they've been obstructed since they've been formed. And some of the kids can develop long-term issues like chronic kidney disease, et cetera. And they need to be closely followed by nephrology and urology as well. Okay, so they can have effect on the kidneys long-term. The ureter, some of these kids have reflux from higher pressure voiding because their bladders are not so healthy, and they have hypertrophy of the detrusor muscle of the bladder due to the obstruction. So it's almost like lifting weights. This bladder has been working hard to get that urine out since the kid was, in utero. So a lot of times they have urinary incontinence. We call it the valve bladder, essentially. So they usually, I follow them long term to help them with their bladder issues as well, get them dry, et cetera. Make sure they're not getting infections. Follow their kidneys on ultrasound and with blood work. Just to give you an idea, it's not something like we fix it and the kid's fine and he goes off. This is a condition that can end up with chronic kidney disease and end-stage renal disease and result in dialysis and transplantation. Just to give you an idea, it's not super common, but these are the kids that get that, unfortunately. It's not your UPJ obstruction or even your reflux, or, back in the day, we used to think reflux was a lot more concerning than it really is in damaging kidneys long term. Okay. Lung effect on other organs. We mentioned pulmonary hypoplasia, and that's the most common source of mortality. The most important determining factor in long-term renal function is what? I don't know if I mentioned this, but so in other words, which one of these is really associated with how well the kidneys are going to do long term? Yeah, it's D. How dysplastic they are, how poorly they formed. If they're crummy kidneys to begin with, guess what? By me fixing the plumb, it's not going to make them any better. If they're poor kidneys, they're going to remain poor kidney. They need to be closely followed and monitored. Predisposition to renal failure is certainly dysplasia, most important. Recurrent infection certainly can take damage to kidneys, and they can take a hit from that. If they have persistent obstruction, high blood pressure, et cetera. Okay, we're almost done. Urinary ascites, reflux, and dysplasia, and bladder diverticula all offer which advantage to patients with them. Having these things happen at the same time, how do you think that might help the kid with an obstructive process? I don't know if you're going to know this one. This is, so it's a pop-off valve. So in other words, what damages kidneys from obstruction is high pressure. Okay, so if you have release of that pressure from a leaky plumbing system, they're having ascites from urinary, then it relieves some of that pressure from the obstruction. Or if you have reflux, where the urine in the bladder, it refluxes up one side rather than both sides, it can relieve some of that pressure and or diverticula in the bladder makes the bladder bigger. It's an outpouching. It's more places where the urine can go that's not going to be causing the pressure to be so high. So I often say to the patients, I'm basically a plumber. You got to think about the physics of all that when you're treating the patient too. Anyway, the VURD syndrome, that's what it's called essentially. The notion that the kidney is protected by that pop-off mechanism. A 2-kilogram premature infant with valves and multiple medical problems is stable at 2 weeks of age. We don't have any scopes available. So what do we do for this kid? I mentioned this earlier. I don't know if you remember, but it's B. We divert the urine from the bladder through the skin. So we make a cutaneous vesicostomy until the kid gets bigger, or we have scopes available. We have scopes available here, but it's just an option you can do to get the bladder drained. That's all we want to do. We want to relieve that pressure for the kid. I talked about the valve bladder syndrome a little bit with you. In spite of, like I said, in spite of draining the kid and getting him fixed surgically with regards to the obstruction, he's still going to have long-term sequelae of that obstruction in the form of, poor compliance of his bladder, poor sensation, leakage of urine, etc. And we could probably skip a lot of this. There is a test that we can do called urodynamics, where we can fill the bladder with, this might have been an extra slide that got moved in there. We can fill the bladder with X-ray dye and take pictures of it like a BCG, but the catheter has a special pressure sensor on it. So we can actually measure the pressure at different volumes within the bladder. And that's a test that we can do to get a sense of how stretchable that bladder is and how healthy it is for the kid. I'm just going to mention this briefly because we're kind of getting out of time here. There is intervention at some centers for this condition, so you can intervene in utero. Usually it's a maternal fetal medicine is involved with this. And essentially what you can do is have a catheter placed. It's like a little stent. It's like an amniotic, it's like a shunt, essentially, from the bladder into the amniotic fluid. So it's like instead of a vesicostomy, you just have a little tube that goes from the kid's bladder, the fetus's bladder, into the amniotic fluid, and that will drain it until he's delivered. It's high risk, of course. Any intervention that's performed in utero is high risk, but just to show you some pictures of how kind of we can do this. Again, usually it's the larger centers that could intervene, high risk of complications, as I mentioned. That can, obviously push the envelope a little bit onto what we can do for these kids earlier on. Circumcision, I alluded to this throughout the talk a few times. Circumcision is something we still commonly do. About 80% of American men are circumcised still. However, there are medical benefits to this: decreased risk of sexually transmitted infections, as well as decreased risk of penis cancer, penile cancer. It also is a decreased risk of urinary tract infection within the first year of life. So we offer this for kids with urological abnormalities to help diminish the risk of getting an infection. Obviously, the benefits do outweigh the risk, regardless of the indication for doing this. Just to give you an idea, the number needed to treat to reduce the incidence of UTI in the general population is about 100. Okay, so you got to treat 100 kids to reduce the incidence of one UTI. However, if you have a kid, if you're selective about how you do circumcision, you only take the kids with recurrent UTIs, reflux, valves. You only need to treat 4 to 11. So in other words, it's much more efficacious if you're selective about it, and you don't have to do as many because you're really helping the kids that most need it. However, a lot of people still sign their kids up for circumcision regardless of any other urological abnormalities, because we're still circumcising a lot of kids in this country, at least. Good. So indications, obviously consider with boys with history of UTI, reflux, valves, or prune belly syndrome, which is another condition. You probably know this already, but contraindications to doing a neonatal circumcision. If the kid has hypospadias, I often like to see them first to decide if it's severe enough of hypospadias, I can use the foreskin to help in the repair. If they have an abnormal foreskin, like a hood deformity where They don't necessarily have to have an abnormal meatus, but they can just have a abnormal foreskin. If it looks like that, I wouldn't do your normal clamp method. I don't know what you guys typically use, Mogan or Gomco. Yeah, okay, yeah. So it's harder to do the circumcisions when there's abnormalities like that, because it's hard to get the foreskin completely within the clamp. I use a Mogan clamp typically, but the same rule applies really. You shouldn't do that. If you have a webbed or a buried penis, if it's any concerns about reservations that you have about doing it, it's okay to put it off if you don't feel comfortable. The worst thing to do is to do it when you don't feel comfortable, and God forbid you have a glans amputation or something like that, which is rare, but you don't want to get yourself into that situation. This is my last slide or two here, just wrapping it up here. Thanks for your patience with me. So urology is plumbing, guys, right? Like I said multiple times. And it comes back to this image here, and how we can maximize the urinary tract and make it work the best it can is stay hydrated, pee frequently, urinate frequently. Make sure the kids are not constipated, because constipation can have a significant impact on how the urinary tract works and how the bladder empties. I mean, you might have seen it yourself when kids come into the emergency department with complete urinary retention if they have impacted stool in the rectum. Okay, so it's good to make sure that they're having regular bowel movements that are soft, that they're urinating frequently, that they're staying clean down there, that little girls are spreading their legs when they're urinating and not trapping some urine in their vagina, and vaginal voiding, we call it, which can act like a nidus for infection. All of these things can kind of contribute to getting something like a UTI, but I kind of just mentioned this already: staying hydrated, correcting constipation, adequate perineal hygiene, spreading the legs, etc., keeping the area clean, wiping in the proper direction, and then frequent volitional voiding. So certainly urology is plumbing. Reliable intake and reliable outflow is what we hope for. So that's my talk. I covered a lot of material here. I thank you for the opportunity to give the talk. Does anybody have any questions for me? Otherwise, I'll end there. Okay. This is my contact information. If you ever have any questions, patient you want to talk about, call me. If you ever want to spend some time with me in the clinic, you're welcome to. Just let me know, and I can have you come in, or the operating room for that matter, if you'd like to. Okay. Best of luck to you guys. All right. Thank you.
Yeah, girl. Yeah, girl. That baseline. We rolled. Oh, you're sassy.